There we go. Just check. Can you all see that? Okay.
Yeah.
Yeah.
Thank you. Yep.
Thanks, team. Thanks, Rob, for covering most of the themes. And I do agree with all the themes which you have actually presented on your last slide. So I'm Shiv, one of the renal consultant working in Manchester. So my first slide is about to tell everyone that we do know that a kidney transplant is the gold standard treatment for end-stage kidney disease for those patients who can have it. And when you say the patients who can have it, because the patients has to go through a lot of tests, they do have some eligibility issues, and if they're fit enough to have a transplant, then they should be offered a kidney transplant. And what are the advantages to give a kidney transplant? It helps to live longer. It improves the quality of life. There's no need for long dialysis. It improves the physiological reserve of a patient. They have a high energy levels. It makes their life a bit more simple. They can travel, they can work easier. There will be a few restrictions, what they can eat, what can drink, and definitely has improvement in the fertility after the transplantation. But there are certain facts about the transplant. We do know that the first kidney transplant successfully started in 1960 in UK. 30% patient who are established in renal failure deemed medically suitable for transplant. It improves the patient's survival, graft survival. And if you look at the 5 years graft survival, it's close to 90%. But other things to look at that when the patient goes onto the waiting list, they have to wait longer. If they are going for the disease donor transplant, the wait can be up to 3 years. And if they do have a living donor, then average time between 3 to 6 months based on their workup. And the factors that can affect the length of time while on the waiting list could be anything from the medical issues to the tissue typing to the presence of antibodies or their ethnicity. This is just a slide which I always present whenever I have chances to do a presentation that just tells about the magnitude of the problem. So last financial year, we have close to 5,600 patients waiting for kidney transplant, and out of which only 2,300 patients had a transplant. So there's a gap between the patients who are on the waiting list and actual transplants that is happening in the country. And if you look at our Northwest demography, we are close to 10% of the UK population. We're 10% of the land size of the England. We have close to 600 patients active on the waiting list, close to 500 patients in Liverpool, 500 patients in Manchester, and close to 170 patients in Liverpool. So why am I telling you all those things? I'm probably just telling you to give you a hindsight that there's such a gap between the demand and supply. And that probably tells you why the patients has to wait longer to get transplanted. But what happened to the patients in this waiting time period? If they have to wait for 3 years minimum, but if they are highly sensitized, they may need to wait up to 10 years. So when you have to wait for such long period of time, it increases the morbidity burden, it increases the risk of a death, mortality. It has got a negative physical effects on them in terms of their quality of life, the frailty. They may not be as good as they were at the time of listing, and they may have encountered some access problems. They may need a lines, they may need a fistulas to work on, they may need to change the modality, and everything has got a negative effect on them. The long waiting can cause a psychological stress. They feel more isolated, they may get frustrated, there's a sense of uncertainty. And definitely if you're a longer waiter, you have to wait long to get a kidney transplant, it has again a negative impact on the post-transplant survival, both in the terms of the patient's longevity and the graft. So what can be done? So they should have their annual medical reviews, or they should have their frequent medical reviews so that they can stay fit enough to be get transplanted. So this is our current model, which looks like. Now we have a three different, uh, we have a two transplant centers across the regions, and we have a five different reference centers which refer the patients to these transplant units. And each unit have its own protocol or a pathway where we do a assessment, but there are most of the units have some commonality. In terms of the frequency of the reviews, uh, kidney transplant recipients do get annual review once in every 12 months. And if you're on the SPK list, then you get a review once in every 6 months. What happened in these reviews, we take the revised history, makes them make sure they are not getting any new illness, they don't have any new medical or surgical issues, they haven't developed any allergies. We talk a little bit about their social history, and and then do a bit of clinical examination around their fluid status, their dry weights, looking at their height and weights, and calculate their BMIs. And during that history taking, if you come across a patient who's got a high cardiovascular bundle and developing some anginas or some ischemic issues with their chest pains, then they are managed as per their local cardiac pathways. If they develop any vascular issues, then they're sent to the team to look into the vascular issues by going to their vascular pathways. In terms of the investigations, we repeat the transplant recipient screening, make sure there does not have any viral infections. In terms of a cardiac testing, it is a bit controversial, but on a whole, the practice in some centers we do ECG once in a year, some center gets an ECG once in 2 years. And if you're the echocardiogram, some centers get the echo every 2 years if you're on the kidney transplant list. But if you are on the pancreas transplant list or you have a valvular heart disease, they get an annual echoes. Now, again, the stress testing, it's again not very uniform across the region, but we, we try to stratify those patients. On a whole, if you're on the pancreas list, then you get a stress testing every year. Chest X-ray, again, it varies from center to center. Some patients get an X-ray once in a year, some may get a once in every 2 years. Cancer screening, this is as per the NICE guidance for the breast, cervical, and colonic malignancies. So this is what we actually do for the patients who are on the waiting list and waiting long enough to get a transplant. We're going through different themes in the last few months, and we thought we need a bit more than that, than just what we're doing in the practice for many years. We probably need to know a bit more information around what does their physical ability look like. You know, are they independent? Do they need any help? Are they walking with the crutches, or they have got a recent uh, event happen which may lead to some sort of disability? Because everything has an impact on the post-transplantation recovery. And if we don't have an up-to-date information about their physical ability, and by the time they come for the transplant, there's so much they can do to recover early in the post-transplant period. We want to know a bit more about their mental well-being, how their mental health looks like. Have they been in touch with anyone who could help from the psychological perspective, how their mood looked like, and which again has an impact in the post-op recoveries. We want to know about the support network around them. Do they live alone? Do they live with someone else? Do they have any dependents on them? And what happens if they stay longer in the hospital after the transplant? How they're going to manage the perioperative period and then post-operative consultations when they have to come to the clinic very often. What we do need is to have a bit more risk and benefit discussions during these annual reviews, so that it won't come as the surprise for them on the night they've been called for the transplant. And most of the patients may not recall the discussions what they have at the time of listing, and it's a very long gap between the listing and the transplantation. Financial implications, Rob did mention one of the themes that we would like to know how they are employed, they're self-employed, they're working privately or they're working for national services, have they got any insurance, and if they're going off the work, what can be done to support them. And in my experience in the last few years, I don't think so. We discuss in detail these things with the patients, probably because of time constraint or the other factors. In terms of the investigations, I've given you some numbers where the patient should have certain testing at certain frequencies, but there's no rationale how we are doing the things. One thing is to actually start thinking about doing the functional status screening. We have the online scores, such as a DASI scores and modified DASI scores, which actually helps to stratify the patients and then give us a threshold if they need any further investigations. We should be considering doing the functional status assessment to give some objective scoring, such as a 6-minute walk test, incremental 6-minute walk test, or timer up and go. We need to start thinking about their frailty business. We don't have much input about or information what happened over the period of time in terms of their frailty. We do do a clinical frailty scoring at the time of listing, but when they come for the transplant after 6 years or 3 years being listed, we don't have any trajectory to guide about their frailty. And if it is the case, if you do have information upfront, we could also involve the multidisciplinary teams. We can think of referring to the prehabs to improve the chances for to improve the recovery and the transplantation outcomes. So what are the advantages of annual reviews? I put the 5 R's. It helps to better risk stratify the patients. It reduces the suspension on the waiting list. It reduces unnecessary investigations if we have a valid objective scoring or assessment screenings. It reduces the cancellation on the day of the surgery, because that is the one thing which a common theme come across during these meetings, that patient did not have such investigations done on the timely manner. But if we have a risk modification or risk stratification scores available to us, and that justify whether a patient needs or doesn't need the investigations, it actually reduces the cancellation on the day of surgery. It reduces the risk from the surgical procedure itself. You will be aware of what the patient is going to go through and what the expectations and what sort of post-operative cares they need, whether they have to escalate it to the high dependency care or whether they can be managed in the ward, and what the post-operative recovery would look like. The whole idea is to re-look into our annual review to improve the patient outcome from the transplantation. Thank you so much for listening to my talk.